So there was some sort of satisfaction that, well, our youngsters are safe, our children are safe. But gradually and gradually, this involvement of older age group started coming down, then the middle aged group, वो भी हमने tolerate कर लिया. But of course, there were occasional involvement of pediatric age group also. But after we finished, or we are going to finish our second wave, now there is presumption, there is speculation that we are going to have third wave. And this third wave is perhaps will be involving our pediatric. And this fact, we the parents, we the grandparents, for them it is difficult to swallow, difficult to tolerate. What is their problem? What is going to be the ultimate outcome? You know it very well that the second wave has shown so many changes, so many variations than the first wave. The prolonged illness, prolonged pulmonary complications, deadly pulmonary complications. The role of vaccine started in January 2021 in India. But believe me, each and every part of society in India is worried about the fact, what is the relationship of COVID to pediatric age group? So this is our topic, what we are going to discuss in next 2 hours. We'll try to finish this topic within time. So, earlier we have extended, but this time I'm sure with the help of all of you, we'll definitely try to finish by 7 o'clock. And as usual, before I joined this webinar, I was also watching India versus New Zealand test match, the final. And the opening batsman for our inning is again Dr. M.C. Mishra. Dr. Mishra, we all know that he is a very strong pillar for medical profession, headed All India Institute of Medical Sciences, Delhi, a respectable vice chancellor in Jaipur, and he had added so many facilities for our country, including advanced trauma life support system, and so many. It is difficult for me to enumerate. So I'd like to invite my friend, Dr. M.C. Mishra.
Very good opening, sir. Very good opening.
Thank you. So, will you like to have a starting remark?
Yes, I would very much. And thank you so much, Professor Agarwal, Amreshji, for putting up this discussion today. It is very pertinent, very timely. The only positive, there are many positives also through this pandemic, which we have discussed social aspects over last 15 months. But one more silver lining through this pandemic has been from the beginning until now that our younger generation, as you rightly said, the children and grandchildren, and we all know when it's something happens to our children, how we are affected, the parents and grandparents. They are the future of the nation. They are. We have a lot of hope in our younger generation that they will take it forward. And the silver lining, what I said, that globally we look at, including India, that the children for some reason or the other have been spared of this menace, this pandemic. If we look at the data last year for 2020 from US, there was some data available where they showed 8.5% children below the age of 18 years were impacted by this COVID disease. In India, during the first wave, the data from Health Ministry suggests about 4% Even if we say that's an underestimation, maybe it is 10%. So I put it around 10%. Children have been impacted below 18, between ages and below 5 years of age. There have been some cases, but the silver lining has been that 99.9% children have recovered at home without much problem. Occasionally, some children developed severe multi-system inflammatory syndrome and required hospitalization, and occasionally there may be a death also. Of course, we have experts here. I would not like to encroach upon their time. So we are all eager to hear each one of them. Professor Narendra Arora, who is the lead for vaccination program of India, Dr. Sunila Garg, Dr. Neelam Mohan, Dr. Shifali, Dr. Nandini, Dr. Arvind Garg, all of them. We are looking forward to listen to you and learn about, in case in third wave, although we look at the recent Zero survey data released, the interim data has been released yesterday, which has suggested that the zero prevalence or zero positivity amongst children below the age of 18 years has been as high as 90%, in some areas 50%, as low as 50% in Agartala, and also in adults. So the children have been exposed to this virus, and fortunately they haven't developed severe disease. We hope that even in third wave they'll be spared as they were in the first and second wave of pandemic. And that also gives us little insight that even despite this much exposure, there have not been many hospitalizations, many hospitalization in critical care units. We'll also be enlightened about the status of vaccine for children by Professor Narendra Arora. What is the status? So we look forward to hearing each one of them. So thank you so much, Professor Agrawal, Amreshji, for putting up this discussion, which will give insight, because this was very much needed in today's times when everybody is talking about third wave and its impact on, specifically on children. I think that is something which we all are keenly looking forward. Thank you so much.
Thank you, Professor Mishra. I think I fully agree with you that so far in India, in Indian scenario, the impact on pediatric age group had been, number one, very less in numbers, and that too, if there are, perhaps it remain mild, moderate, and there may be occasional chances of going into severity, very serious, or there may be something more than that. But I was personally in touch with my old institution where I was the director at Chacha Nehru Bal Chikitsalaya. That is one of the good referral center for the capital city. And talking to their people, their doctors, and I think numbers what Dr. Mishra gave, I think there was some similarity what you were talking about. So now with this, and there is a definite good report from All India Institute regarding the seropositivity, and that brings a very, very relief in the mind of all of us. So my next speaker is going to be my old friend. We started our career practically together, NK, in All India Institute of Medical Sciences, and Dr. Arora, who had been professor of pediatrics in AIIMS, and thereafter he decided to lead the very important organization for research, which is a global organization in CLAIN, executive director. And by virtue of his involvement, not only in the clinical pediatrics, but in the field of epidemiology and in research, Today, he is the president of All India Institute of Patna. He is president of All India Institute of Medical Sciences, Jharkhand, and heading so many committees, including the very important, very powerful committee for the COVID management for the country. So it's my pleasure, NK, to invite you. And we all want to hear your experience, what you feel about the latest research, especially in the field of vaccination and pediatric age group. Over to you, NK. NK, अपने को unmute कर लो.
Yeah. Thank you very much, Professor Agarwal, Arunji. In fact, it's some time that we have been sharing the podium together, but it is such a pleasure always. And we were in the same wing, if you remember, when we were in.
Yes.
Yeah. So I will start straight away with the pediatric one. Whatever global data is available, pediatric population has no special predilection for the virus, if at all, because ACE inhibitor density is less on various tissues. So therefore, it appears that may be one of the important reasons that the asymptomatic infections are there, but symptomatic and severe infection and fatalities are extremely uncommon. The second point is that in first wave, 2 to 3% children were there below 10 years, because that is what is of major concern. 10 to 18 can be managed in a regular COVID facility, but below 10 years, they require parents, they require a special kind of ICU care. But in the first round also, there were 2 to 3% sick individuals, and fatalities were rare. Even in the second round, the fatality is same percentage, about 0.4 or 0.3%, 0.35% of all deaths are pediatric in the second round. The diseased individuals were 2% or 3%. The problem in the second wave is that the denominator of cases has exponentially increased. So last year, maximum cases were 1 lakh. And therefore, if I take 2%, it becomes about 2,000 cases. But today, maximum cases are 4 lakhs and for several days. And so the background will become 8,000, 10,000 cases. And children become visible because otherwise we don't see them sick otherwise. So there is this perception that pediatric population was more involved, but the data, the national data very clearly suggests that there is no special predilection. Children were involved in the same proportion as last year. The admission rate as well as the fatalities were also very similar. Having said that, I think this concern for managing pediatric cases and preparing our health system, gearing ourselves to provide appropriate clinical care is not only appropriate, but I think most relevant and urgent, because if a child less than 10 years gets disease, infection, the possibility, the whole system has to gear itself in a different manner, vis-a-vis if I have a older child or an adult. Now, the second thing is that vaccines. But prior to vaccines, what Dr. Mishra was telling us is right, that seroepidemiology is showing consistently the exposure risk or the infection risk in under 18 and under 10, very similar to what it is in the rest of the age groups. So there are less than 10 years, 10 to 18 years, 18 to 45 years, 45 to 60 years, and more than 60 years. In fact, I must tell you, in phase second wave, we are doing a study at 5 sites, a cohort study. The proportion of children exposed was about 10% more as compared to adults. So children are likely to get more infected, but fortunately less disease and rare, severe or fatality. So that is very important. So, but children play a very important role in the viral transmission dynamics in the community. They get infected, they pass on the infection to their peer group, and from peer group to their other families, from their own family. The second is schools have not opened in this country ever since last year. But I'm aware that most of the Europe primary schools, particularly, they have never closed. And the reason is that we, as pediatrician, we know cognitive development of primary children is very dependent on peer interaction. The and so and this became very apparent very early. By April, May last year, it became apparent that children are not do not become sick. But in the process, in Europe, a lot of teachers died because they picked up infection from children of primary school. So so there are a lot of this information is available. Now, third thing is that need for vaccination. So I think now one can understand why vaccine is important. First, to protect them, but equally important is to protect their environment, family environment, community environment, and school environment, so that they can go to school properly. And as you are aware that within our country, there are two pediatric trials going on, one with Covaxin from 2 years to 18 years. And I think this is one of those rare trials globally anywhere where children below 10 years have been taken up, or below 5 years have been taken up. And the other is DNA vaccine based cadilazidus, which is between 12 and 18 years. And currently Pfizer vaccine has finished a trial. So they have started adolescent from 10 years onward, the children can be immunized. We hope that by the fourth quarter of this year or first quarter of next year, when I think vaccine availability will improve significantly, we should be able to offer vaccines to our children and adolescents, class 8, 10, and 12 classes, so that next session we can have regular classes for our children and grandchildren. And I will stop at that. And if there are any questions later on, I'll be very happy to do that. Over. Thank you very much.
Thank you, NK. Thank you, NK. Just a small question before we proceed further. As per the announcement of our Honorable PM, 21st June, the new policy of vaccination is perhaps to enhance the capacity of vaccination is a big way. Had there been announcement, what are the steps?
Okay, I will outline the whole process. So, in fact, on 7th, 8th, in the week of 7th April, we had the peak of up to 4.5 million individuals getting immunized per day. And immunization centers at that time were 75,000, out of which about 8 or 10,000 were private sector. Now, this time, the purpose is that we should be able to immunize 1 crore or 10 million children, individuals every day. India has the capacity to immunize huge number. In the pulse polio day, that each round of NID, National Immunization Day, in 1 week, I do not know anybody would like to venture. India immunizes 17 crore children in 7 days. Coverage is almost 98%. So we have the capacity. And therefore, the target of having immunizing 1 crore individuals of all age groups is not at all overambitious. It is completely possible, and the mathematics, I'd say. So each immunization center without difficulty can immunize 100 to 150 children, individuals every day, the way it is at the moment, including half an hour waiting. But the system is going to have at least 100,000 public sector immunization centers. And even today, if you open up, only 5,000 or around 4,000 are private sector, but bulk of it is public sector. Private sector now has been offered 25% vaccines, and smaller cities, smaller nursing homes, doctors with 2 beds, 4 beds will be able to, just like they are able to get other vaccines, they are now we offered vaccines in that. So we expect a great partnership with public and private sector. Public sector will take care of most of the urban poor, urban lower middle class, and slum dwellers, and the whole of rural India. While it is expected that private sector will take care of most of the middle class, upper class, and the elite of the society in urban areas. So this is also, COVID had thrown an opportunity. I know Arun has been working throughout his life for this public-private partnership, and COVID has provided that opportunity to bring the two together. And I hope this synergy is further reinforced.
Thank you, NK. I think this very important public-private partnership will prove to be a boon in the area of vaccination, which we are looking for. Please stay with us, because there are likely to be more and more questions for you. Our next speaker, I'm taking permission because our colleague Dr. Shefali Gulati has requested, because she had some commitment at 6 o'clock. Dr. Shefali Gulati is professor of pediatric neurology and looking after the developmental pediatrics in All India Institute of Medical Sciences. And I think her contribution in this field is enormous, especially Shefali in the field of as mentioned by NK also, our children are not going to school. There is definite lack of cognitive stimulation. What is happening to them? And in relation to COVID, please.
Thank you, sir. Thank you for the invite, and thank you for allowing me to permit before, because I have a session between 6 and 8 I'm chairing, and I'll keep logging on to this also and log in from the other one to the another mobile.
Please.
Thank you so much. So basically, as sir has pointed out, like you talking about COVID-19 as such in children, the cases had risen and now it's now falling on the second wave. But we have seen that in children, it in less than 20 years, it is 12% only. So that is remaining the same. And as sir has already mentioned about the ACE receptors, and also, the children have strong innate immunity because of the general vaccination and good regeneration capacity. And they are just found to be in different studies less infective, when they're saying in household contacts, the elderly were getting more infected than the small children. And modes of transmission, just mentioning because this airborne transmission which has come, and that is why what has happened is recent second surge, we saw that whole families got affected because we do not have good quarantine facilities in our households, so that is why the whole families were getting infected. And the clinical symptoms which we see in children can be pre-symptomatic, asymptomatic, and the classical what you see as a fever, cough, and cold, and also diarrhea, which has been noticed. And neurological remains still an atypical symptom which is there. And in an unpublished study, actually is under publication, which was done from AIMS, they have again found most commonly was fever followed by cough and throat problem and pain, abdomen, and vomiting. And they did find neurological problems which were there in about 7%. Basically, what happens is more than 80% of hospitalized patients, as sir has already mentioned, they are getting well fine, but those who are getting hospitalized, about 80% of them may have neurological problems. And one thing very importantly, the MISC, the MISC, the multi-system inflammatory syndrome, is seeing more percentage of people having neurological problems. And neurological manifestations can be like seizures, can be refractory status, can have stroke, have encephalopathy, Guillain-Barré, acute encephalitis, and that can be there. And it has been shown in a series from the West in around 22% of the patients out of 1695 children they had seen. In our Indian meta-analysis, they found that non-specific headache, fatigue, myalgia was seen in around 17%, although classical significant complications were seen in only 1%. out of the around 4,000 children seen in the meta-analysis. MISC is very important, as I mentioned to you, having more neurological complaints, and with the pathophysiology being besides by the direct viral entry, because they may have mild disease because or the severe disease later on leading to MISC. Either it is direct viral effect and the endothelial injury, or the pro-inflammatory state and the cytokines. When you're talking about adolescents, they see symptomatology, as very rightly sir had also pointed out, that adolescents go on with like the adult care, almost an extension of that. So they also had headache, dizziness, encephalopathy, myositis, taste and smell impairment. The smaller children did not find any of them, although small kids may not be even reporting, but even in those who can report, they've not found the taste and smell problems in most. One more important thing to see, those children who already have pre-existing neurodevelopmental challenges, they are actually more prone to develop this infection because they're dependent on caretakers, and they have to require frequent hospital visits, and they may have comorbidities, and they are, always like reflux and all. And because of the, lockdown and practically routine hospital services not being available to these children with autism, cerebral palsy, have not been getting much, therapies which they were getting. Some online forms have been made, but they are not optimal. So that is very important, and this is all worsening. Not only direct infection, the COVID time is causing problems to those who had neurodevelopmental issues and pre-existing other neurological problems. Some of these children do not understand the reason of social distancing and may not use masks, and that is very important. So there are some guidelines which have been made that those children who are having some already systemic disease, like who are on Duchenne muscle dystrophy on steroids, or on having any West syndrome, who are on steroids or any other immunomodulating drugs, how to handle them during this time. And it is very important because their routine follow-up also has got affected, and some telehelpline has already been a very saving grace, and which has developed over last 1.5 years. And another aspect, psychological and behavioral impact on the children who are having COVID-1, that is number is less, but the typically developing children as well. That is very important because of the closure of the schools and all. That is important to understand, and they are with the homes and all, they are there, and there has been all the teachings have been on the online platform. And we did a meta-analysis last year, and we did study, we studied 15 studies from across 10 countries, and we found that 79.4% children, 79.4, you see, about 80% of children had behavioral psychological problems negatively, which were there. Out of 34.5% of them had anxiety, 41% had depression, 42% had irritability, and around 31% had inattention. And 22.5% children had significant fear of COVID. So I think, when they're watching the TV and all those debates and all, when they're talking about the second and third wave, it just scares them, especially the adolescents who understand. And some of them are having sleep disturbances as well. Another aspect we should not forget, the caregivers of the parents who are there are also having anxiety and depression of 52% and 27% respectively. So we have to, as pediatricians, and we have to handle not only the child, but you have to target and counsel the entire family. And we have to give them a psychosocial support, and that is important to be seen. And for all these patients who are with special needs, we have to develop online programs and provide teleconsultation and support. And we have to understand that even for adults, there is domestic violence and child abuse, which has increased because of their being in the houses because of lockdown. So we have to develop telemedicine facilities only, and counseling sessions which have to be there to help them. And that is how, and we have also seen one more thing, that these patients are coming late. They are coming late to the medical centers. So in the last 1.5 years, we have seen a rapid increase in the number of neurotuberculosis, which are more complicated. So they are coming late. For the milder problems, they're not coming. So there has been a surge for this. And I also want to mention that COVID doesn't mean that only acute COVID. You may have ongoing symptomatic COVID, you may have post-COVID, and you may have a really long COVID. Why I'm saying neurological and psychological issues and stresses associated with that are profound, and which we have to address. And there is a term post-intensive care syndrome, not for COVID. It is there for any child who goes into intensive care. This can also lead to a lot of cognitive dysfunction, psychiatric problems, and they can have problems with the physical dysfunction. So we have to keep this in mind, and we have to provide psychosocial psychosocial support for the child and their family. Another thing is the routine immunization has got affected during the pandemic time, and that is why there is a possibility that there may be resurgence of these vaccine preventable diseases in the near future. So that has to be also addressed. And teleconsultation and telehelpline is very, very important. And face mask, WHO said that up from 6 years and older they can use, but IAP is recommending 2 years and above you can use face masks. And the younger children who are there, they can be, you can, if you're using face shields, it has to cover the entire face. Face from the sides till the ears and the balloon under the chin. And for a child who is less than 2 years of age, the child should not be having the any face mask or any shield. The child, when the child has to be taken out, if it is necessary, then the carrier of the child has to be covered with the blanket and provide minimum exposure outside, maximum time it should come out. So we have to understand that the delayed access to medical care, which is an additional thing which is causing a lot of problems. And there was suddenly recent guidelines from the Lancet group, just to want to say that we understand that pediatric population is affected less. And what happen when the child, most of the children we are able to follow up at home only, and they have to watch for danger signs. And one thing is there, if the child has COVID-19, then we have to admit the child. When the child is younger child, is not an adolescent, we have to keep the parents there even if they are COVID negative. So that issue has to be kept in mind. And if the parent has COVID positive and a child is small, parents have to be taught that you can use different ways to communicate with the child. Give him a separate phone and be through smartphone and connection with their. So, but isolation has to be done. And then there is a concern whether it is causing developmental delays. There is lack of cognitive and social stimulation. So there may be some delays which are there. So that is why we need to develop online, programs so that you have a multisensory stimulation, and why the need of starting the schools early as much as possible, keeping all the immunization and everything in mind. So the many neurological problems which were there can also have sequelae. So basically the mask thing I have already highlighted to you, and you have to keep in mind the psychosocial aspect of the children and their caregivers. Very important. Younger children, the parents should be playing with them not only through the smartphones and the tabs, should be playing something like carom and chess, so as to they can be engaged in something which is non electronic. And also for adolescents, parents are role models, and the children can be involved in some house the work at home as such, so that you engage them. That is important. And keep in mind to see holistically the entire family, and that will be very, very important. And especially for children with special needs. For special needs, we need to have, we are on the process of developing an AI-based module for multisensory stimulation of these children for autism and cerebral palsy. And we should have to tell parents to continue on the breastfeeding, keeping in the precautions of the the social distancing and the obviously from the others, but for the child we'll have to keep with the masking and all that is there. These were the few things I thought from a neurological and neurodevelopmental aspect we would like, the parents may like to know and we need to understand. Thank you.
Thank you. Thank you, Shefali, for a very, very extensive coverage of the neurological as well as the neurodevelopmental aspect. And
Arun,
yes.
Arun, can I ask a question?
Yes, please.
Yeah, Shefali, thank you very much. If in summary, if you can tell us that children who are suffering from neurodevelopment disorders, and if they happen to acquire COVID infection, what is their risk of getting severe disease, hospitalization, and death? So whether, among those 9 or 10 neurodevelopment disorders, plus some of the inborn errors of metabolism, which involve gray matter, white matter degeneration. Yes, so overall, if a child with these disorders gets COVID infection, what is their risk of dying and getting severe disease?
Sir, in the data which was there, the risk of patients who having a pre-existing where children having a pre-existing neurological problem, the risk of dying is quite high. I can give you the figures. When in the AIM study, which is under publication, sir, out of which out of the 402 children, there were only 13 deaths, right? Out of the 13, 5 had neurological problems, which was there. And when they have, when they saw even in the West literature, which has been shown that there is a significant number of them, if they are having, they're going to have mortality and sicker, they'll be sick. So that is why I was part of this Lancet commission when we were making the guidelines. In the flowchart, it is there. If anybody, obviously not only neurological, any other pre-existing.
Just a rough. So if I have to
Yeah.
counsel any parents with high risk status,
Yeah.
how should I tell them? Because I think the basically risk has to be computed between children with high risk conditions versus a normal children.
Yeah. Sir, two things are there.
Whether the risk increases by 10 times, 20 times, because in adults it increases by 17 to 20 times.
There is one thing, there are two things. There are these children may be on immunomodulators or they may not be on immunomodulators. Both of them have a different risk. If somebody who has been on an immunomodulator will have a higher risk and chances of problems, and it becomes there is a big problem. Those who are on chronic steroids, when they was having a surge, there was a very important debate which was going on how much to go on giving these on steroids, because they were like on West syndrome, they will be on neuromuscular disorders, they would be on steroids. So that was important. And according to one of the data, if you say out of 1695 patients, 22% from the US had neurological abnormality, and patients with neurological abnormality, out of the 365, 81 of them had underlying neurological disorders. And when they saw association of COVID-19 with fatality, 14 of the patients, with neurological involvement had died, and out of which 3 deaths were related to basically, related to cardiorespiratory death, and 11 were related to neurological problems. And children with neurological involvements who had more chances of having a neurological deficit, which was seen in 20 out of 365 versus only 2 of them who had non-severe neurological problems. So a person who is having a neurological problem is going to have a higher chances of mortality, because the ends have not been so high. So I cannot give you the exact percentage. I can just quote the study which I did, but then you will have a percentage of them who will die and high percentage of them who may have sequelae. So that is why in that Lancet Commission, it has been suggested that those patients who are having any of these chronic problems should be, keep under close surveillance and possibly hospitalize them and monitor them. And the thing becomes more tricky with those who are being already on immunomodulators. And another thing I mentioned to you, sir, that MISC has had more complications. Although MISC data is coming up to 60% of patients with MISC have been shown to have some neurological problems.
Shefali, I can see that Dr. Arvind and Dr. Neelam wants to give some comment.
But Dr. Arun,
yes.
In continuation of MISC, what percentage of your patients, Shefali, had MISC, and what is the mortality in MISC?
Sir, MISC ka to data has just now been coming, sir. I mean, we don't have that much, but whatever the various, hamare yahan to aa raha hai, sir. We are seeing various kind of patients, and we have had a patient who passed away last week. But that, I mean, our total data is just been collated. But from the from what is there in the West, from that data what we have. So that in that data, sir, in that data we have had from up to 60% of them who are having, MISC.
No, what is the mortality?
Of MISC are having neurological problems, up to 60% in different cases. I mean, because from the West.
Mortality is 60%.
No, not mortality, sir. I'm saying they are having this.
What is the mortality in mortality in MISC?
The mortality in MISC with neurological wala bhi, they are saying the neurological wala jo I'm saying with which I'm giving you the data from the West, which was not the MISC one, which was the normal one. I said 14 had died, out of which 11 were directly neurological related deaths. Only 3 were respiratory related deaths, which were there. Out of the 14 who had died, and that was a number which was there out of a total of 1365.
That you are saying neurological. What I am saying, Non-neurological MISC, and what is the mortality?
So non-neurological MISC, currently the things are on, sir. So I mean, I do not, our data we do not have from our place, but generally their response is good. In our institute data, which I showed was only of the COVID-19 thing of the last few months. The MISC they are still collating. So I do not have our MISC data, sir. From
So
our
So
Thank
can
you.
I add in
I
over
think-
here? Sir, we had a presentation from CDC because we are going to take a multicentric study with Share India and CDC Atlanta. So there they shared the data that, you know, they had 4,018 children, out of which 36 succumbed to MISC infection, you know, so that is there. So this was the latest
That gives
presentation.
some idea, yes. That's what I wanted to know.
So, and then we have got large number of data from Institute of Child Health in Chennai also. So, but quite a number of children they do recover. So, thank you.
I
Thank
think
you.
now we will proceed further. I know Dr. Neelam and Dr. Arvind wants to comment or ask, but I'm going to proceed further. And whenever you are speaking, Arvind and Dr. Neelam, please, you can give. We will request Shefali to remain connected as far as it is
no,
possible.
sir, I will remain connected at 5:55. I log in from the other laptop, so I'll be on this. Yeah, thanks.
That's right. So now I will, as per the schedule given to me by Mr. Tiwari, I would like to invite my friend Dr. Arvind Garg, who is a senior pediatrician in Apollo, Noida, and he is very actively involved in Indian Association of Pediatricians, and the person who had been taking very keen interest in COVID care in pediatric age group. Arvind, would like to share your views about past and future.
Thank you very much, sir. It's really my pleasure to be with.
And sorry, I mean, the only thing I did not say that Arvind and Sunila are the two genius husband and wife.
Thank you again, sir. Thank you again. It's my really pleasure to be in this August gathering of Dr. Arora, Dr. Mishra, Dr. Neelam, Dr. Shefali, so many, and I can see Dr. Nandini here. But, you know, continuing to Dr. Rawal, that, you know, the cricket match, you know, the bowler who throws the ball, the batsman, he is not aware what type of ball is going to come. It is an in swing, out swing, spinner, fast, medium pace. So coronavirus is like a bowler. It's like a ball which is going to hit us. So we are the batsman, there's the bowler. And it's going to, how it's going to hit us, sometimes now we have a Delta wave, now we had a different, now we have Delta virus. Now I don't know which virus is going to come. So this is how it will affect all of us. Regarding my concern, I have a very few presentation. I'll speak now on this. And I will share you. Can you all see my slide? Hello?
Not yet, not yet. You have to share your screen.
All right, yeah. I'm not able to do that. 1 second.
Have you been allowed to share by Mr. Tiwari? Amresh?
Can you see now?
It's coming up. It's coming. Yeah, now it's there. You can slide presentation.
I have this. I am presenting. You know, this data I have taken from my colleague. I think is going way a different way. So this is what I'm going to share. This has come from my colleague, and I'm sharing a data from my Dr. Jacob John and Dr. Dhania, which came just few days back. And this, I'm talking on this basically about the third wave and about the vaccination to the pregnant woman. This has become quite important. The Regarding quickly about the first wave started on 6th of March, and Dr. Arora is there. He'll comment on this. And it peaked in 191 days. It took up to 16th of September. During pre-peak cases, it was 5 lakh, 51 lakh, 15,893 cases, out of which is going on. Out of which total peak cases at 51 lakhs, 15,893 cases, out of which 26,785 cases per day, and post-peak cases were 51 lakhs, 8,904, out of which 49,124 cases per day. And it ended on 28th December 2020. So it lasted for 104 days. So total wave lasted for 295 days, up to 42 weeks, almost 10 months. And overall, there were 1 crore 22,000, 2 lakh 24,791 cases, out of about 34,660 cases per day, which means 1 million cases per month. In second wave, it started on 9th of March 2021, which peaked by 6th of May last month 21, lasted for 58 days for more than 8 weeks, and cases till peak were 1 crore 24,000, 1 crore 1 lakh 40,661. That means 1 lakh 76,560 cases per day. The surge volume, you can hear that from the last time, this time it was 6.6 times. And the surge speed was 3.3 times. So it was 1 million cases per 6 days. So time to reach million was 5.5 faster. So you can see how serious it was. So a wave becomes requires sufficient population. The leftover after first wave was 700 million plus 65,000 births per day. That comes to, in 10 weeks, 75 million children. Variants greater than R0 emerged, which remain unnoticed. And we failed to vaccinate at least 20 to 30% of population, and we encourage crowding. Or 40 to 50% population are vulnerable after first wave. We were left with D616G. There could not have been second wave, but new variant emerged. There was a group of 10 laboratories assigned for monitoring 5% viruses for doing genome studies, but probably 0.2% did this. They did the work. The rest did not do. The entry of alpha, beta, gamma variants were unnoticed until the second wave emerged. The Indian mutant Delta Kappa spread fast in Maharashtra and West Bengal. The RO of DG6146A was 1.5 to 2, and RO of Delta was probably 4. There was no specific study, but epidemic profile agree that this was how the RO of Delta was like 4. The first wave, the secondary infection rate was 30%, and the second wave, it was almost 100%. So everybody in the family, including children, were affected. This alone is sufficient for increased number of cases. So third wave is mere speculation. Those who speculated and predicted, I don't know why. Those who failed to predict second wave, that is one of the reasons people think, which I still don't agree, that they were diverted attention for failure. Anticipation and steps of mitigation is taken is good. I don't know if you can imagine, if you cannot predict the gender of a wife, the baby is going to come, whether it's a boy or girl, it's always 50-50. But in third wave, the probability is more of 10:10, 10:90. So the lesson is the first wave was due to Wuhan, Hubei, and D616G variant. The second wave was due to variants like alpha, beta, gamma, delta, kappa. For 10 weeks, January, February, and early March, there were low steady numbers, but 7th day rolling increased by 15,000 per day. There will be post second wave lull will emerge to be anxious. We'll have to be anxious alert by then, and urgent genome surveillance needed. Only faster spreading genome variants can cause third wave. So herd immunity, the first wave, 40 to 50% were infected. So remaining 560 to 700 millions were infected. The balance are almost 700 to 840 million. The second wave infected almost 75% of balance, which is 525 to 630 million. So total immune is 1085 to 1330 million. The balance is just 70 to 315 million. It is not enough for third wave. So vaccination will enhance herd immunity. The vaccination of 20% with 2 doses will avoid even the remotest possibility of third wave. It should be achieved by end of August. Dr. Aurora was talking about it. This is time to investigate booster vaccination and hypervaccination. We brought in the coverage. This is their talk. These are the headlines, different how the children are affected. But Indian Academy of Pediatrics very clearly said, pediatricians rule out third wave effect on children. This is the data till 4th of June 2021. The up to below 19 years, if you see that there, the yellow is male and the blue is female, and this red is the number of deaths. Total positives were 7 crores 9,000 70 lakhs 9,941 cases. Out of death was this, fatality it was this much. Below 15 population, they were up to 5 to 6, 0 to 4 years, and up to 19 years, only 6.18 were infected, and deaths were only 0.47%. So you can imagine how less was death. And this is what Dr. Arora was saying, speaking that number that denominator and the numerator both have increased. That's why so much of visibility, but the ratio has remained same whether it's the first wave or second wave. These are the number of cases in Uttarakhand and Kerala, in Andhra Pradesh. This is the United Nations number of COVID-19 cases added in past week for children and adults. These are the children, these are the adults. And in the United States, total number with COVID with 3.9 million cases, out of which pediatric was 14%, and out of which 0.1 to 1.9% needed hospitalization, 1.3 to 3.2% of children total with COVID hospitalization. Mortality was 0 to 0.21%, which is this is exactly what we had. But what we read in Brazil, there were so many children dying. I'm just coming on that. But there's only media report, no scientific analysis. But it said over 800 mothers have died, hundreds every month, and there's evidence of increased female virulence in pregnant women. I myself am aware that a lot of antenatal mothers who develop COVID, they have a lot of problems. There's more death. They're producing children with IUDs, preterm labors, who have severe asphyxia, who are developing a lot of complication. So the question is, why so many children in Brazil are dying of COVID-19? Experts say that the variant happens to be leading to higher death rate among pregnant women. Some women with COVID are giving birth to stillborn and premature babies, as I said. So my only humble request is, government should, Dr. Arora is here, I request the government that he should speak to the people that government should allow to vaccinate every pregnant woman with COVID vaccine. We know that we have been giving tetanus diphtheria vaccine to all mothers. Rabies vaccine is given in pregnancy. Influenza vaccine is given in pregnancy in the first week of pregnancy. So COVID vaccine specifically, I'm not talking about the Covishield, which is a vector vaccine. I'm talking about inactivated vaccine like Covaxin should be given to all pregnant women so that we have less morbidity and mortality. Thank you.
Thank you, Arvind. Perhaps you have given us not only Indian scenario, but global scenario also. And after listening to that, there are so many queries which are coming up, even in my mind, and I'm sure my other listeners will also be very curious. But let me finish my presentation first, and then we'll get back on the question answer session. Our next speaker is Dr. Neela Mohan, our friend, our colleague, who is chair of the pediatric gastroenterology in Vedanta Hospital, looking after pediatric transplant and whatnot, had been associated with double helical for ever since I remember, right from the beginning.
Thank you
Neelam?
so much, Dr. Arungwal. I have huge respect for you and I keep complimenting the enthusiasm with which you moderate session is truly applaudable and commendable, and for all of us to learn from you where the spectrum of your interest is humongous. I would like to start by thanking the Double Helical and paying my regards to my seniors, Dr. N.K. Arora, who's been my mentor. I've been trained in hepatology by Dr. N.K. Arora, and whatever I am today, I humbly bow down to him. And Dr. Mishra, who's been always initially an advisor, but a good friend now. And we share the media forum. And I think I've had 60 media forum, of which if not 40, I would have shared with Dr. Mishra. So with that, I didn't really prepare, but I thought I would see what the others are speaking, and I would add on to what is not being covered. And so there's nothing like a slide that I would want to share, and I will give comments. One is I thought about the face marked, which Shifali said. I think she said IAP said 2 years. So I wanted to clarify that ministry guidelines in India too has asked for 5 years, that to use the mask less than 5 years. But yes, CDC suggests that one can use the mask above 2 years of age. Second point I wanted to talk about the incidents which Dr. Mishra said. Are you there, Dr. Mishra? Maybe your video is off.
No, I'm there.
So,
I'm there.
great. So
Dr.
Dr.
Mishra
Mishra, they have
will be with
a lot
us.
of meta-analysis that have come. Sadly, in India, and this is a very good point that have been raised by the last 2 papers which have come from the Ministry of Health Welfare in this month, June. 2 papers they've released out for children. One was on the management, and the second was beautifully on infrastructure development and how to go forward. So they have talked about this deficiency in our system where we were not able to collect the MISC data. But let me tell you, I have spoken to all my colleagues in a lot of places, whether it's Maharashtra, Rajasthan, Kerala, eastern side, Chennai, and all of them are seeing a lot of MISC cases. And if I look at the Western data, the extrapolation is the average of metalysis, which goes to thousands, is 0.15%. That is, you would see. So for every 1,000 cases of COVID that you would see in children, or 800 cases, you would get 1 MISC. And there are data. Yesterday, I was listening to a talk from an expert from Chennai, where they said that in phase 1, they admitted 130 children, but they were predominantly those mild cases, like where the parents were admitted and that. But in the second wave, he said that the whole hospital was adult. So it was like 1,300 adult patients, and they admitted only 19 critical, and out of which 6 died. So second wave, sadly, there was no space for us to accommodate children who went into moderate disease and severe. So though you said in your introduction 99.9, with due apologies, I would differ that it is not 0.1% who get severe. So moderate to severe is to the tune of 5 to 10% in children too. But severe is whether they get admission. So that doesn't mean all severe die. I agree the mortality. So coming to mortality in children, the Lancet paper, which included 10 hospitals data of pediatricians coming down together, and they took only hospitalized data, 2,600 hospitalized patients data. So it's a skewed data because it doesn't tell you non-hospital. Out of that, less than 10 years, the mortality was 2.4%. And 40% who died had comorbidities. So that would add to my another comment to Dr. N.K. Arora's thing, that if we need vaccine, we are strongly urging to use the vaccine in this comorbidity, because of the 2.4% mortality of the 2,600 children admitted in 10 hospitals, 40% were with comorbidities, which included neurological, renal, and patients, and respiratory and cerebral palsy. That's what neurological patients in that. So less than 10 years, 9% were those who were admitted with severe disease. So that was trying to answer your information about MISE. And I would like to say that we've now simplified MISE. We say MISE with no shock, MISE with shock, and MISE with Kawasaki-like syndrome. So if you have no shock, then we don't want to use IVIG. We use steroids, 1 to 2 milligram per kg. See over the next 2-3 days, if they are progressing, adopt that protocol. If they are with shock, then you use IVIG over 12 to 18 hours. Use slow over 24 to 48 hours if there is cardiac ejection fraction problems or cardiac issue. Similarly, in Kawasaki, we use same IVIG, same dose for there. And along with it, we use methylpred 1 to 2 milligram per kg. Having said that, in patients who go into shock, which we have seen in my hospital, we admitted around 25 patients of MISC. And they present to you either with this, and the milder ones come to you just with pain, abdomen, diarrhea, vomiting. This is how they present to you. Sometimes we have used 10 milligram per kg. Earlier, we were using 10 to 30, but now the ministry guidelines is to use 10 milligram per kg because of the few cases of this thing being reported from Mumbai. You would have all heard about the, the mucor cases that came from Mumbai. In view of that, now the guidelines suggest we use only up to 10 and then go to biologicals if we need beyond that. And few comments I thought I wanted to make about the interesting part about what do we need to do in case we are worried for children. So first part, the last 2 days have been so useful in our country because we got to know that the data which Dr. N.K. Arora hinted on, the interim data, they wanted to collect 10,000 patient people data or serosurveillance, but they released the interim data, which was only for 4,500 people, of which 700 were children, less than 18 and more. And in that data, they said that the prevalence for urban population especially was as high as 70%, similar to the adult population. And for rural, it was 55 and 63%. So that is sort of a good news to us that probably a lot of children got already affected in the second wave, and maybe these antibodies which are secondary to this infection may protect us from the next third wave, which we were scared of. So I gave you a good news, but I give you another sad news. That sad news is, what is a variant? So variants are defined as when we have the virus, when it is in the environment and multiplying a lot with more people available. When they multiply a lot, then in that case you would have the mutants developing. The virus mutates because of its rapid multiplications. And there are two mutants. One is variant of interest. That means there is a mutation, and we know it can affect people who are going to be in the community and more. The variant of concern is one where we show increased transmissibility, increased severity, or decreased efficacy of vaccine. And we know that the WHO had initially called the Delta variant of India as variant of interest. And subsequently in June, we called it as variant of concern because we showed that it was 5 times more transmissible and probably more severe. We say probably, but more transmission is for sure. And we know 99 as of the date June 18th. The people who are in UK who are seeing a third wave is Delta variant that we are seeing in them. So what is going to be the Delta plus variant, the K417? Is it is going to be a worry? The answer now is we don't know, because we have called it as a variant of interest. We don't know whether this K417N or the Delta plus variant, which is seen in Europe, Asia, and USA, and not much except a few cases in India. That is what we are worried, that we need to identify these hotspots where these are being identified and curb them. So based on that, the Ministry of Health and Family Affairs has suggested it is time we build our infrastructure to be taking care of children, because we know we will not be able to provide vaccine to children initially. We have, as Dr. Arora said, 1 crore a day. From July onwards, we need to target adults. So the children are right now not in there. So they suggested 4S. The first S is the staff, how we are going to take care of the doctor staff, the nursing staff, and how we are going to answer that. I will reply on that. Second is the stuff. How do we improve the infrastructure, the oxygen mask, the catheters, and all the necessity of HFNC and the ventilator, because we know that the ventilator for children are little different in HFNC. Number 3 is space, and I will discuss on that. Number 4 is the system. So to answer the first staff, we think that we should take care of medical students and the Ayush doctors, the senior doctors. How? The senior doctors can be used for counseling of the patients and communicating with them. The younger doctors can be used for simple like saturation monitoring, oxygen giving, this. And the efficient intensivist should be utilized for the ICU care and the telemedicine care, and this next 100 days, if you may like to call, because we don't know whether the COVID, if Guleria says it, next 8 weeks or 3 months. We think that the next 2 months, we should train our pediatric doctors for the training of, resuscitations and ICU training and all that. Because we know that the government doctors, pediatric doctors during the second wave work for adult patients. So during this time, why not we improve our care ourselves during this time? So we want to recruit more nurses and train them. We want to get the more protocols. All that is needed is how to planning this system. That is what needed, with very little of funds which they have proposed, how to get it from CSR and NGOs, etc. And I will answer questions if Agarwal says and not take. But a simple example, if you take a district hospital of 300 bed, we want 20 beds, which now the present guideline, out of 300, they say that 32 or 10% according to the guidelines should be children. So 20 is ward, 8 is HDU, 4 is ICU, 4 is emergency. We suggested 10% increase in this infrastructure. The medical colleges should do hand-holding of the district hospitals, and 5 regional centers of expertise should be identified. And these regional centers, like say Haryana, Delhi, state, whatever, 5 regional centers of expertise where they will do hand-holding for all the district, the medical colleges and the tertiary, and be able to transfer to them those cases that are not. Protocols have been beautifully laid. We know how to treat COVID mild, COVID moderate, COVID severe. We know how to treat MISC without shock, with shock, Kawasaki. We know what to tell the community health worker. We know when he should identify those 5 signs: child lethargy, seizures, not accepting well orally, grunting, and saturation less than 94, refer. Less than 94, moderate. Less than 90, severe, go to level 3, tertiary care. 90 to 94, moderate, needs oxygen, can go to level 2. So I can go on, Dr. Arun, but I don't want to take your time. But I just thought I'll give you a glimpse about how everybody is working. The Ministry of Health Welfare, the Niti Aayog, the all individual pediatric doctors, as well as IAP, trying to educate through this beautiful today what you did. We will be able to spread this knowledge of, disseminate this knowledge, which is the key strength, because when you have a crisis, that is the mother of invention and mother of an opportunity to improve your system. And it is the system which makes you win. And that's why I said in the 4th system, that was most important, because we still can take care of stuff and space, and we need to improve the system.
Thank you. Thank you, Neelam. I think it's very important for us that the golden hour concept for many emergencies, the same way you have given a very good concept and warning that though the second wave is going away and the speculation regarding third wave, but we have some golden 30 days or 60 days or 100 days. We do not know.
Correct.
Right? And we do not know how many days we have. Or perhaps it may not be required, but it is the time for us. Infrastructure development, in second wave, we felt oxygen shortage. Very quickly, the government was quick enough to create infrastructure for oxygen, ICU. But remember, I always say, because I have been medical education, manpower, skill development. And I'm so happy that our Prime Minister launched day before yesterday the crash course of COVID-related skilling. You must have read, you must have heard.
Yes, sir.
So those,
Yes,
all these things are very important for preparing ourselves to fight out third wave, which we wish should not come.
Yes, sir. We are very sure, based on the sero surveillance data which came through this MIA AIMS interim study, which has shown such high good sero prevalence both in rural and urban. So I think we are in that comfort zone, though we realize only 5% of the country is vaccinated right now, and we have a long way to go, because our dream is to do 100 crores. But based on that data, we think that since most of them would have been infected and they have their antibodies, so we should be able to get the T cell immune response in our systems. And if at all, we also know now that even if we get the variants, so far the variants Delta, which we saw, it did help us in reducing the severity. If not, it did not help great in reducing the infection. We know that those who had 1 dose and those who had 2 doses, nearly 70% of them still had the Covishield still had an infection, but majority of them had mild to moderate. And that's what Pedro was trying to say, that maybe they had little cold and we should not look into that. We should look that severe infection, these vaccines, that they did not, this variants did not deter them. So I think we are quite optimistic that the third wave will not be a disaster this time for people in India. But having said that, we still don't want to lower our guards, because it is in all of our hands to ensure that we educate each and everybody around us to say that we are at risk because of you, and you better not lower your guard.
Thank you, Neelam.
Uh,
Also,
and
you pointed.
I
Arun,
would
can I
want a
ask a
comment
question?
from Dr. Arora if
Yes,
he's there.
yes,
Yeah. Arun, I wanted,
please.
thank you, Neelam. So I am a mother in a remote rural area. What are 4 or 5 symptoms? I do not have pulse oximeter. When
Very good.
I would say my
Correct.
child
So
is
in a
serious,
remote,
and when should I take it?
correct. So the simple thing that we need to see in children is that we say we are not able to do saturation in majority, as you said. So we say if it is fever up to 3-4 days, it's fine. Fever is prolonged and not responding to paracetamol or associated with signs of dehydration due to diarrhea or vomiting. That is, the patient is sluggish, vomiting excessively, not passing urine, breathing fast, or using some accessory muscles of breathing, intercostal retraction. That is what sleeping excessively. These are the signs when we educate the mother to move. And for the respiratory rate, more than 5 years, we simply teach them that if it is more than 30, and 1 to 5 years more than 40. So therefore, even on a telehealth checkup, we ask the mother, she can show a facility, and this is how we talk about the SRAC muscles, the breathing, the lethargy. Majority of the deaths can be prevented simply through ORS diet. 30% of the children can have GI manifestation, which is not to be forgotten. And in pneumonia, whenever they have grunting and whenever they have getting blueness, that means they need to go to level 3 tertiary care center.
Can I
Yes,
say
yes.
something?
Arvind,
Yeah,
please
it's a
comment,
simple.
then I will take over.
Any child, if you tell the mother, if child is in a right environment, when the child is with the mother, if the child is smiling, looking at the eyes of the mother, that child should have good saturation, good pressure. Now, if the same child, if the mother is not able to, his question was, less than 3-month-old child or 3-year-old child, Dr. Arora?
Yes. So that's what I said, lethargy, somnolence
So
is not
if the child
responding,
is
vomiting, diarrhea.
able to drink fluid and is able to clear urine, not dark urine, this is generally taken as a good sign. Child should not, or if you can see, normally they're not able to watch the respiratory rate. If we tell them just watch the abdominal movement, that is enough for them to understand what is the respiratory rate. Thank you.
Let me summarize for the audience कि अगर मेरे बच्चे बहुत रोता जा रहा है, पानी पिलाने पर भी या खाना पहले खाता नहीं है या पानी पिलाने के बाद भी रोता है, तो पॉसिबिलिटी है कि सैचुरेशन की प्रॉब्लम है। नंबर 2 कि बच्चे को अगर लूज मोशंस हैं तो बहुत प्यास लग रही है और डिहाइड्रेशन के सिम्टम्स होंगे, बार बार पानी मांगता है या दूध मांगता है और लूज मोशन हो रहे हैं। 3 कि बच्चे की पसली चल रही है, सांस लेने में तकलीफ है और पसली चल रही है। 4 फीड नहीं लेता या सोता चला जा रहा है। 5वां, so I think if we translate this into very simple so that an ordinary mother understands, I think that will be better.
Perfect.
Definitely, sir. And it is the time to revisit our integrated management of neonatal and childhood illnesses, where we taught in a very simple manner to our paramedical workers, how to, make ask, look, and feel. You have to see that whether, it is a case of diarrhea or pneumonias, and then how to refer. So this has already been given in the hand of paramedical workers, and it is a time to revisit between the pediatricians, between the public health personnel, to educate them in a simple manner, because particularly where we have got 67% of our population, we need to kind of focus upon multi-purpose workers, and it's the time now to reorient them and That is the need of the hour.
So आप muted है Dr. Agarwal, आप muted है.
Dr. Arora, was he saying something?
Sorry.
नहीं,
I think
मैंने इसको सिंप्लीफाई जानबूझ के, क्योंकि अडल्ट में भी 4 सिम्टम्स होते हैं एंड आई थिंक बड़ों में भी 4-5, बच्चों में भी 4-5. अगर मेरा बुखार पहले हफ्ते 5वें दिन के बाद भी बुखार बना हुआ है या तेज बुखार आ रहा है, 1. नंबर 2, सांस लेने में तकलीफ हो रही है. नंबर 3, बात करते हुए खांसी इतनी हो जाती है कि मैं पूरी बात नहीं कर पाता हूँ. चौथा, कि अगर जो है मेरी छाती में दर्द हो रहा है. दिस इज फॉर अडल्ट्स एंड नो ऑक्सीमीटर रिक्वायर्ड. छोटे बच्चों में भी हुई बुखार अगर 4-5वें दिन के बाद भी मेंटेन्ड है. नंबर 2, सांस लेने में या पसली चल रही है. 2, लगातार रोता जा रहा है, जो हाइपोक्सिया का सिम्टम होता है. चौथा, कि अगर डायरिया हो रहा है तो प्यास उसकी बुझ नहीं रही है और उसकी वजह से भी रोएगा. तो ये जो सारे सिम्टम्स, इसको बहुत ट्रांसलेट इस तरीके से करने की जरूरत है. और हम सोचते हैं हमारी शहर की माएँ ज्यादा समझदार हैं, तो ये हमारी गलती है. हमारी शहर की माएँ भी उतनी ही समझदार हैं.
remember, mother is mother. Every mother is very intelligent.
मैं
हाँ,
एक
तो
कमेंट मारना
इंटेलिजेंट का
चाहूंगी
मतलब ये
डॉक्टर
हुआ कि
अरोरा.
उनको सिंपल लैंग्वेज में बताना है.
जी,
And,
डॉक्टर अरोरा.
नहीं, बिल्कुल
I
सही
just
है.
see.
I think we'd like to
Really-
proceed now, because then we'll be short of time. Please allow us to proceed. Our next speaker is Dr. Nandini Mondkar. Dr. Nandini, thank you very much, Tiwari ji. Because of you, I met my own product of Maulana Azad Medical College. I never realized that such a wonderful person who is from Bangalore had been working in developmental pediatrics and had been doing exclusive charitable work for this group of pediatric age group. And I appreciate, Nandini, we have been discussing COVID versus non-COVID impact on pediatric age group, school going age group, no school, only this laptop and iPad, total lack of interaction, perhaps hardly any interaction with the parents also, because parents are also busy on their laptop. घर के बाहर जा नहीं सकते और अपने बच्चे 1 या 2 होते हैं, तो obviously they are totally isolated. So with this sort of observation,
sir, sorry to intervene. I would like to welcome to Dr. Vijay Agarwal.
Dr. Vijay Agarwal ji, thank you very much for joining.
I was here already. Quite
Okay,
some time.
okay. We will seek your comment once we finish.
No problem, sir. I'm listening.
Thank you, Dr.
And, yes, Dr. Nandini.
Thank you, Dr. Agarwal, for your kind introduction. And I run a trust. It's not really free all the time. We also charge parents who can afford to pay. But today we'll talk about what is the mental health, the status of mental health in children during COVID times,
Yes.
So there are 2 phases. The first phase, we had the lockdown, where the mental trauma was all about prevention, because everybody was in the house. Initially, if nobody knew what was happening, the children were very happy. The parents were in the house, they could run around, there was no school. They really thought they can play around, and parents also, the online, the work was not started. So they had some time to bond with the kids, or they could, that's a time when many parents told me we came to know our children, that what are their needs, because they were so busy working, or they're so busy, the children are out of the house, that it didn't make much. So the first phase also did not bring in so much of trauma, except for this social isolation which they had. And if the parents would fall sick, they would have this clinging, and I'll talk about that. But the second phase of lockdown became a very traumatic thing for the child. So what happened was, now there were infection, there were people dying, the grandparents affected, the neighbors, it was under so much of television, so much of trauma of the parents looking at it, that affected the children a lot. Now, if you see, the child is affected depends upon the age of the child. We have to look this under different age. What happens to children below 5 years? What do they do in school age? What is the adolescent, how they are affected? And their children with special needs like autism and the other kids, and of course children in difficult circumstances like the poor socioeconomic condition, which has got the impact. So we will briefly, within the next few minutes, I'll go through each one of them in a very simple way and tell you all what it is affected. Now, what happened to children below 5 years? Below 5 years, when they see, it was even the mask was a fear for them. What is this appendages everybody is wearing? They didn't know, and for them, wearing it was, some others said by 2 years they wanted to wear, and the child was very uncomfortable. They would cry, probably breathe, or so that itself was a trauma for them. What does do? It leads to anxiety. Anxiety, what do children do in anxiety? The anxiety, of course, they are many, the previous speakers have said, they cry, temper, tantrums, sleeplessness, not poor appetite, not able to play, clinging to the parents. And then second thing was breaking the routine. Even the preschool who used to go, there was no routine set. They would get any time, they would sleep anytime. The parents they thought it's holiday. So that it's quite traumatic for a child who does not have a routine, And of course, there's a complete breakdown of the healthcare system because they couldn't go for their immunization. The sickness was all over the phone. The doctors did not write the clinic. All this affects a child in its own way. And then, of course, the worst thing was parents started working from home. When they work from home, they're in front of their laptop all the time. Although the parents are at home, they cannot give time to their children. They see that is even more traumatic to a child who feels that the child feels, I'm neglected. My parents, they cry and the parents say, no, take her away, or and there was no help in the house. Their regular maid who used to come is now in quarantine or in a lockdown, could not come. So their parents were stressed and the children were even more stressed. And then came simple things like simple celebrations like Diwali, small things which happen in the house would be a great enjoyment for even a below 5 years old child. That was big. They would present symptoms, as I told you, a lot of behavioral problems, temper tantrums, clinging to the parents as if, the anxieties, will they go away? What will happen? Was the very, very difficult thing, especially in the young children who did not know what was happening, but all that they knew, something was wrong and they couldn't figure it out because that brain development did not have that much of frontal lobe development for them to see. But all that they could do was show. And every behavior is a function a child exhibits. Whether it's temper tantrum, loss of appetite, whatever, if the child is trying to convey something that I am stressed out, please help me, I need help. That's what. So how to handle the situation? I thought a simple guidelines to parent is talk to the children in the language appropriate to their development. If it's a 2-3-year-old child, you're not going to big sentences. You're going to probably use 2-3 words and say, "Ha, beta, I'm there with you. Don't worry. Hold them tight. If you can, or tell them that it's okay. I'm around." Even in a quarantine mother who's there in the next room, the child says, I can't go and see her. She's there, but she's not, the child is not allowed. Just give a voice or do a video to show that she's there, but I'm well, don't worry, And so very, very simple language, and best for a below 5-year is a play to understand the situation. You do a lot of play. For example, I've just given here, play with the sanitizer, how to wash hands, how to, why do you wear a mask? And, you can do it with a doll, you can do it so that the child understands that, oh, this is what it is meant. A play is what is very, very necessary. And of course, parents themselves have to be very good model and not talk about it and beef and say, and express their anxiety in front of the child as much as possible so that the child feels good. And of course, do not be harsh on their behavior because their behavior is showing their stress. So great lot of empathy for this age group is so much necessary to understand it. Now, when you come down to school age children, they're a little more mature. They know what is happening. They have understood there is a pandemic, but they still have a fear and anxiety, fear of death. I still vividly remember one 7-year-old child got COVID symptoms, and his grandmother grandmother was very serious. Her D-dimer was something in thousands because she had some problem and she had to be taken away to the hospital, which the Karnataka government gave her 30 kilometers away, and the father had to take the grandmother. And there was another small child. The mother was the first floor, and the grandmother was downstairs. This child, the first question is, Aji will die. I will also die. The fear of death comes to them because they think so many. And this media, which is one thing, I think when you have a school go children, I think we should cut down seeing visual media which talks about COVID and death and shows those pictures all the time, because it really affects the child. And then came the virtual classes, which were so new to them. 8:30 to 3 classes for the kids, for school going kids. And it was, they could not pay attention. They would not sit in front of the TV. They would run away, and the teachers would grumble. The parents would, force them to do this. And they didn't know, they've never attended this before, so that was a big trauma to them. And of course, lots of live events for them, playing with the peer group, going to school, lots of, events which takes place in schools, of all that was missing. So, and the last was, even they were not able to grieve. For example, the grandmother died, and this child, they couldn't even go for the funeral. He couldn't even go and see. So that, all these are issues which these children, I've just put a few, there are many, I thought 10 minutes time. So I thought, what could we do with them? You have to talk to them. You have to tell them about the disease. You got to tell them, no, most of us get all right. It is very few people when they're sick, but you are not, you will be all right. And you can easily make them do pulse oximetry and tell them, see, you're all right. You can always make them do temperature check. All these children should participate on this thing. And of course, when you supervise the virtual classes, the child runs away for some time. Don't be so harsh on them. Don't be so apprehensive. Encourage a lot of alternative activities. There are lots of online classes like hobbies, arts, crafts, singing, dancing, whatever the child likes. Make them a part of the household participation, to do special bakery or whatever the child wants to do. These parents have to make and maintain a very good sleep and physical health for them. Sleep should be a very good factor. They should not sleep at 12, 1 or 2 watching. And of course, you should see the monitor the behavior. Are they withdrawn? Are they doing so much of anxiety, fear? This is the most common. Most school children really didn't get affected. Very few got, passed away, but that as you all see, the pediatric data is not showing so bad. And of course, you must also create a virtual peer group for them for the class, so that they can speak to their friends, they can play with them on a virtual game. So it's how to handle the children is very, very important in this age group. Now, if you come to adolescents have full knowledge of what's happening. What are their worries? Their worries are about their future. Their worries are about their academics. What will happen? What happens with the death in the family? Will they have to take over? The father dies. What will happen to my education? And then it overwhelms them so much that they go into anxiety. They can go into depression, irritability, depression. All these are part of it. And many of them have what's called behavioral addiction. Behavioral addiction is to the social media. And many of the mothers are telling me they're spending a lot of time on screen time, and especially gaming. They've started betting and gaming until 2 or 3 at night. And they are when parents say don't do it, they get very irritated with them. They are not able, because parents need to bond with their adolescent. You can't suddenly come into their lives and all the time you've done nothing with them and say that. So emotional bonding those had with them would tell them the situation. Then otherwise, these children were, a lot of them lost interest in academics. They said there is no future for us, and they were very worried. And the fear of the vaccine, not only fear of the disease, adolescents have fear of the vaccine. Now they were going to get it. When we get it at 18 or something, what will happen? Should we take it or not? Then of course they got into a lot of substance abuse, and of course, a couple of them, even there's the cases of suicide which has been reported. So keeping a watch on these. So we have to negotiate with their feelings. We have to negotiate and talk to them. If we are not able, please get a counselor or somebody to support them, support their education, support the counseling. Tell them this is not happening to you. It's happening to the whole world. Everybody is going to lose a year, or everybody will get the same amount of treatment. You're not the only one. So don't worry, but some of them children who told me, ma'am, we have paid so much money abroad, how will we go when there are no exams? The whole year will go, my money will go. The parents, of course, pay lakhs of rupees for their education. So they were very upset, telling. So all this affects the child and it keeps on working in their mind, See, one thing with the adolescent is intellectually, they are fully matured. Emotionally, they're an infant. Their frontal lobe is just started. They don't have good organization. They're developing their organization skills. They're developing their thought. They're developing what to do, how to do. They need a lot of support and a lot of counseling. Then came these children with risk situation. I feel my heart goes out most to these children because there's such an increase in child labor. Because I think the one parent is dead, where they thought they're sending all the children to work in cotton fields, collecting garbage. Then this COVID orphans. Where will they go? Who look after them? What do they feel that they have nobody for them? That's a sexual exploitation. The girls, as you all know, and many of them went into early childhood marriages. Even 2 days back, we read in the paper, in the middle of the night, they wanted to conduct a child marriage, So somehow they came to know. And they what little education they had, the government schools were all closed. So even that was lost for them. And their child, one of the greatest scare was that nobody cares for them. And what do? They get into criminal activities and they get into bad habits because of it. So these children, I feel, are the most vulnerable. Whatever program we do, we as a pediatric society, somewhere along the district, have to look into how to take care of these children. And children with special needs, of course, there's a loss of therapy, lot of pain because they don't get proper healthcare is broken down. As you said, if they get into neurological symptoms, if they had COVID, and that is even worse for the parents. So the whole childhood goes into a lot of mental health, though the report have said, there's only one publication which has come out on all this, which is from China. They've said about 25% of the children were in severe anxiety, and there was depression about in 18%. Others were mild. And one of the greatest thing we have to do with every age group child is to build hope to say that this is all temporary and this will pass. This is not permanent. You will change. The situation will change. You will feel better. And I think that hope is what I think we need to give it to children. And I feel I only have so much to say in the time allotted to me, that we have to stand up for our children. We have to tell them the protection of why it's important for them. And we also have to stand with them and say, and each age group guide them as to what is best they can manage with their limited intelligence and limited emotional development. Thank you.
Nandini, thank you very much. Your last 10 minutes talk not only is for the counseling of children, it has counseled us also. We, the parents and grandparents, right? And thank you for making us realize that what is our important role. If we are tense, our children are tense, our grandchildren are tense. How important for us to play, to act like a head of the family.
Yes, sir.
Right?
Yes,
keeping
sir.
our worry on one side, but we are the head of family. We have to behave, we have to act like a head of the family. Thank you very much for your very lovely input. And before I invite questions, I would like to invite my two experts, Dr. Sunila, who is my colleague, public health expert, head of the community medicine, advisor to WHO, advisor to ICMR, and whatnot. Can you just give a brief comment? We have been talking about seroprevalence, positivity, going in favor that perhaps we are not going to have third wave, or if at all, it should be less, especially for the pediatric age group. As a public health expert, a brief comment for 2 minutes.
So, first of all, I like to say nobody talks much about disability, but I'm happy that Nandini talked about this. I recently got out a paper on hearing impairment in this masked world. What we realized was the children who are hearing impaired, they cannot do lip reading and all of that. So the paper has got a lot of recommendations because they did not have access to the healthcare system. They could not do lip reading and all that. So this is something which has gone to the Lancet Commission also, which has been noticed by them, and it has been incorporated in their recommendations. Now, the second part, Nandini, what you said was PGI Chandigarh has got 6 comics on Vayu and Corona.
Yeah.
Vayu is a, kind of a, basic person who teaches them everything ABC, that these are available in 28 languages, including Arabic language. That is one thing which we have to see and make use of, because either adolescents can read themselves, or parents can read out these comics to the children. Another thing which is very important is a beautiful infographic booklet has been brought out by AIMS Bhubaneswar on mental health also. These are small but easy to read materials. So this is one thing which we must make use of. Now coming to the question of Sero survey, which was carried out by AIMS and WHO from March 15th to actually June this year. And this had 4,509 participants. Less than 18 were 700 and more than 18 were 3,809. What this seroprevalence detected was that positivity in 2 to 4 years was 42% and 5 to 9 years was 44%, and from 10 to 17 years was almost 60%. But people, we have to see overall picture of seroprevalence was, 56% in less than 18 years, and more than 18 years was 64%. That is one thing which is important. But one thing which we have to keep in mind was that predominantly it was a rural population which was involved: Delhi urban area, Delhi rural, then we had Bhubaneswar rural area, Gorakhpur rural area, and Gorakhpur rural area. So these were the rural areas which were involved. And 75% of the population had got antibodies. That is important. But another thing which came out of this was the persons who had suffered from infection in past, they never had reinfection. So this was the important finding of this. So that means, infection provided them sufficient amount of immunity. So since I've got 2 minutes, so another thing which I would like to point out that we just got out one paper in June issue also, that is strengthening public healthcare systems in India, learning lessons from COVID-19 pandemic. So we have to focus on few important points with respect to the population as a whole and children in particular, because leadership and governance from the pediatric side along with us, so we need to do a multi kind of a disciplinary approach. That will be very, very important, along with health services delivery. So this is where we need to talk about our Ayushman Bharat, keeping in view the needs of children, what needs to be imparted to community health officer, what needs to go to the medical officer and above. So that's how we will be building our healthcare systems. Now, medical supplies, they become very important, particularly in view of pediatric formulations and adults requirements and all that, and along with the bed strength and all, and requirement of oxygen that needs to be taken into consideration. And most important part as a public health person I see is the health management information system. Now is the time to go look back into our health management information system, which has already been updated on the IDSP platform by NCDC, so that basically we can look at what has been the exact data hospital wise, or facility wise, both in private sector, government sector. Look at this whole data with respect to different age groups, and then come out with the recommendations. And also I need to, I'll recommend that when hospital talks about the recovery rate, let's even look at COVID death surveillance response, because you see, now we may not get the data, but we must go to every district, talk to the, registrars of births and deaths. For MDSR already, that means for maternal deaths, we have already got a committee constituted at the level of ministry, of which Registrar General of India is already a part of it. So we must also focus from this perspective also, because surveillance and response will give us answers to these questions. So thank you so much. I think, sir, I finished in 2 to 3 minutes. Thank you.
Sunila, absolutely all right. Thank you very much for a wonderful response. Since the time is running fast, I'm going to request my another friend and colleague, Dr. Vijay Agrawal, who is the expert advisor to Double Helical and the person who had been hardcore hospital administrator responsible for bringing up many corporate hospitals, including Max and Pushpanjali Crossley, and now which is Max Pushpanjali Crossley Hospital. Vijay is president of PAHO and responsible for many initiatives in patient safety, whatnot. Vijay, we'd like to give, we have been talking about pediatric COVID. A brief comment from your side.
Thank you. I will just like to make a very brief comment that during this pandemic and even the fear of the third wave, I am looking at the bright picture is that we are looking at increasing or reinforcing the absolutely non-existent infrastructure, especially in the tier 2, tier 3 towns and in every district and in every village. And I feel that our policymakers and everybody has to understand that it is not only the issue of this corona. This may, of course, after some time it will go, but this is not the end of any particular problems which keep in the to children we can say, and we can give them assurance that this will pass. I hope our politicians and policies makers don't think it just that all right, it will pass and therefore we don't have to do much action. So it is an absolute imperative that we have to look at district level and various level of we should do a gap analysis, because it is not merely buying ventilators and putting it there where nobody will be able to use. So there are many kind of, I would say, spokes which have to be put in place, including like what you said regarding the human resource factor, about the manpower, about the specialists, about the basic people. So I think a huge amount of brainstorming should be done, and this opportunity should be taken to reinforce the infrastructure across the country. This is a great opportunity. And my only submission is we should not look at this only as COVID-centric. When we do this, people in the villages are dying even of non-COVID problems. Today, they are dying of total neglect. They are in the hands of quacks and absolutely, I would say, totally at the hands of the nature. So I think this is an opportunity. And of course, I must say that this was a great webinar and must compliment you, sir, and Tiwari ji for organizing this and the galaxy of people you assembled. Wonderful. Thank you very much.
Thank you, Vijay. I think you are absolutely important that perhaps we are lacking somewhere, and this is the high time to look after those shortcomings, not only from COVID point of view, but in totality. This is an opportunity for us to improve ourselves, our infrastructure, our skills, our whole thinking has to be very much concentrated. And I'm so happy that my colleague N.K. Arora is here. And of course, Dr. Mishra and so many of you are involved in the policy making. And they all will definitely convey a very fruitful message to everybody who is involved in the final decision-taking capacity. I think we will invite the question now. And before I invite Tiwari ji for putting the question, whatever they have received, I'll put one question to Dr. N.K. N.K., can we put a question to you? Dr.
I think it's not here.
Okay. So I think...
Arun, I'm there. Can you hear me?
Okay. Yes, before we put the question from the public, as a moderator, I have one question to you. Sometimes it is seen that after full dose, both the vaccination, people get tested and they find that there are not enough antibodies. And I know somebody has gone officially, unofficially took the shot for other vaccine. What is going to be the official guideline of revaccination?
So you have asked a extremely important and topical question. And
Yes.
the reason is that there is a certain proportion of people who do not develop antibodies either with natural infections
Yes.
or with Covaxin or with Covishield.
Yes.
So I would like to share with the audience that immunity is of two types. One is visible immunity, and that is antibodies. And if neutralizing antibodies are present, they directly indicate what is the overall protective role of that protective capacity of that individual. However, in those who have no antibodies, almost all of them have the invisible immunity or the T cell immunity. And that is the reason that when one calculates the value of one vaccine dose versus 2 doses, you find from India, whatever information we are getting, the protective efficacy is similar. So from Chandigarh, it was 75%. From Vellore, it was 61 and 65%. So the protective efficacy remains same, whether the antibodies are present or not. That is broadly, it appears, the data is emerging from within the country. I am talking now of the data emerging within the country, that it is not necessary, and there is a disconnect between neutralizing antibodies and T cell responses. There is a publication from National Institute of Immunology also on this issue. Now the second, and therefore people who out of anxiety are going in for a 3rd dose of another vaccine is neither desirable nor one should say at this time, one is not sure about the safety. Because when vaccines from 2 platforms are given, the data from Spain and initial data from UK and one other, I think Canada, is showing that the reactogenicity of the vaccines increase if vaccines from different platforms are given. And therefore, these studies need careful design and monitoring, because, for example, with Covishield, there is this thrombocytopenia syndrome. And with Pfizer or mRNA vaccine, there can be myocarditis. Is there a possibility a 3rd adverse event may appear for that? And therefore, I would very strongly advise that we should avoid any any kind of step to take a 3rd dose from another vaccine or the same vaccine also. You be confident that you are protected. Lot of people, I do not know how many of us are aware, in my study, plasmid, where plasma was given, 30% of the plasma donors were negative for antibodies after getting a RT-PCR positive infection. So as far as transferring the passive immunity, their plasma was useless. It did not help. But on the other hand, individuals on their own are unlikely to get reinfected because their T cell are still functioning. So I will stop at that, and we'll be very happy if there is any further question on that.
Thank you, NK. I think it's a wonderful clarification, and I will request Tiwari ji that this particular concept and other related concept in consultation with Dr. Arora should be published in your magazine, because perhaps these are the questions in the mind of public, which should be clarified.
Can I ask a follow-up question, Arunji?
Yes, please.
Narendra bhai.
Haji sir, please go ahead.
When you say that 100% people who get either of the vaccine will develop protection, either visible or invisible, is that correct?
So if it depends what is my endpoint. There are 3 endpoints. One is whether I will get symptomatic infection. The second endpoint is whether I will be hospitalized with severe disease. Third is death. Now, 4th endpoint, which none of the vaccines have studied, is interruption of transmission of virus. So let's forget about interruption of the transmission of the virus. But for the other 3, the mild disease can occur after 1 dose in a large number of people. But even after 1 dose, there is 95% plus protection against severe disease and 98% practically prevention, protection against death.
So,
So we have examples of people who have got 2 vaccines and then died. Let's not name people.
no,
So
that's
I
okay.
was one of the person
Yeah.
who had both the doses of Covishield but got infected, but it was a very mild disease. On the other hand, there are people who were admitted and who expired also. So there is a whole spectrum, but the proportion, as I told you, the risk of death is around 2%, risk of severe disease is 5%, and so that protection is very high. And that is what ultimately makes a difference when you know that the mild disease is like a URI and nothing much is required for in that case.
That's okay. That's okay. My point is, what is meant by efficacy then? When we say Covishield is 6% efficacy.
Efficacy का मतलब, this is a very important question. What efficacy का मतलब क्या होता है, या effectiveness का? So when I say a vaccine is 70% effective, it means if I give vaccine to 100 people, 70 people will not get symptomatic infection. But the information, the next step is how many persons will get severe disease and how many will die. So severe disease and death protection is almost 95%, even after 1 dose.
So what is the difference in then Pfizer and Covishield Covaxin?
सच्ची बताऊं मैं, सच ये है कि Covishield prevents symptomatic infection also up to 90%, 95%, whatever that is number. But 100% protection from severe disease and death is not there even with those 2 vaccines.
Yeah, I know that. I know, that's why I'm asking this. And then how to make sure if visible immunity has not been developed to test for invisible immunity, T cell.
So this is another issue which is actually researchable, because T cell responses cannot be measured. ये एक त्रासदी है that like antibodies we know in milligram or dilution or something, we can do that. But the problem with T cell is that you look at relative to those who are unimmunized, what is gamma interferon production, how many times it is increased, or what is the perforin performance, and there are ELISA spot testing and those things. But none of these are all qualitative tests which tell us that it is present. But to quantitatively measure that, currently the processes are not clean.
Thank you.
Thank you. And I think Tiwari ji, I'm sure you must have received few questions, and please bring those questions one by one.
Unmute Amresh ji.
Amresh ji, अपने को unmute कर लीजिए.
Arun sir, till Amresh ji gets the question, वो एक चीज वो मुझसे पूछी गई थी, I had to log into another one. I'll just clarify one thing. वो पूछा गया था मुझसे कि क्या कि कोई बच्चे को न्यूरोलॉजिकल कंप्लेंट है तो उसके बाद उसकी मोर्टेलिटी कितनी होती है. मुझे फैक्ट्स में बोला था, मैंने नंबर में बोला था, परसेंटेज में नहीं, इसलिए क्लियर नहीं हुआ. एक जो स्टडी लार्जेस्ट है ना, उसमें 1695 बच्चों में 1.2% डाइड ओवरऑल. जिनको न्यूरोलॉजिकल प्रॉब्लम थी उसके अंदर 3.8% मरे, और जो उनका और जो न्यूरोलॉजिकल सीक्वेले रहे हैं वो 5% रहे हैं जिनको न्यूरोलॉजिकल कंप्लेंट थी, और जिनको न्यूरोलॉजिकल कंप्लेंट नहीं थी उनके लॉन्ग टर्म सीक्वेले सिर्फ 0.2% रहे. तो अब परसेंटेज में थोड़ा सा क्लियर हो गया कि न्यूरोलॉजिकल प्रॉब्लम होने से थोड़ा सा आउटकम बुरा है. और जो मिसिक की बात हो रही थी तो डिफरेंट स्टडीज में डिफरेंट है. गॉश की एक स्टडी में 52.8% है, वैसे 8 to 60% तक के रेंज की स्टडीज है जो मैं बता रही थी जिसमें न्यूरोलॉजिकल कॉम्प्लिकेशन है. MC मिश्रा सर आप पूछ रहे थे सर उसमें एग्जैक्ट मोर्टेलिटीज हैव नॉट बीन क्लियर बट दे आर लो if brought up early. And
so
sir,
I would simplify it for you that anybody who has neurological illness at the background and unfortunately the child gets infection, the risk of death increases by 3 to 5 times. Because different studies are showing, because 1.4% and 3.8% people don't understand. the basically risk of death increases by 3 to 5 times.
The same thing, NK,
Yeah.
I have observed while, hello, NK?
सर एनके सर ऐसा ही क्लियर करते सर, वो बैक साइड में भी ऐसी टेबल बना के बढ़ाते थे, वो मेरे को जब पढ़ाते थे तो वो शुरू से ऐसे ही पढ़ाते सर वो
Yes,
टेबल।
yes.
Sorry
So
to
I just
intervene.
wanted to add one thing, Tiwari ji,
Yes.
that while analyzing some of the COVID deaths in one of the hospitals, I realized that adults who were suffering with any disorder like dementia or Parkinsonism or other cognitive domain disorders, their risk of death was definitely higher as compared to the normal adult. Tiwari ji, अब आप अपने questions लाइए,
Sir,
because we are running out of time.
Sir, keeping running time in mind, I have just 2 questions after
Yes.
shortlisting a lot. And these questions from all of the eminent speakers, policy makers, and experts in their own field. First question. This question from Chowdi Bazaar, New Delhi. Fatimika Sheikh, she's asking, just a month ago, I delivered my healthy baby. But unfortunately, I infected COVID positive. Now, am I able to breastfeed to my baby? Is it safe? What would you like to say?
Yes. Arvind or Dr.
Dr.
It is very safe.
Arvind?
All mothers should be breastfeeding their babies. If they are positive, they have to just take COVID appropriate behavior. They have to put the mask and then to feed the baby.
And wash hands.
But their parents are not allowing her to breastfeed.
There is the problem. There's a problem. A lot of people do not know, and even if you see those who are in
And
vaccination
even,
center.
sir, even says she has written to us, she is asking, please understand to my family members, even they are not allowing her to go another room where is a peeping baby is keeping up and their parents is nursing them.
I can imagine this type of psychology in a...
So can I say something on this one?
Yes.
It's very safe to pay. If they're not allowing, ask her to just express the milk at least and give it as an alternative. Because I know this is happening in many houses. So if best is to wear a mask, wash hands and say it's absolutely safe. They can perhaps, in the event, if then also the in-laws don't agree, I think you should express the milk frequently and give her a breast pump, and that could be an alternative if nothing else works.
Nandini ma'am, we should give counseling to the in-laws, I think.
In-laws.
Absolutely. That's the first.
Actually,
if they agree,
the problem, this is not with this. You take any vaccine. This is just this. Corona, parents have, especially the elders in the family, you see why there's vaccine hesitancy. Why did it problem with the polio? It is just, there's no alternative to the education. It is just educate, correct information should go to them, and it will sooner or later they'll understand. That's what I'd say.
Tiwari ji, दूसरा question क्या है?
Next is from Dr. M.C. Misra, who is the one of the part of the policy maker, and Dr. N.K. Misra, N.K. Arora, and Dr. Agrawal self. Sir, question is very interesting. Mr. Johnny Thomas from the Hyderabad, he is asking, the government is talking about the vaccination for the prevention of third phase, more than 14 years. But what about that less than 14 years? I mean to say just 5 to 14 years. What about them? Is the government is concerned about them?
सारा डिस्कशन तो उसी पे था.
पूरा डिस्कशन ही उस पे था दोस्त.
I think he is not able to get it. That's why he asked.
Dr. Arora can briefly summarize for him. And for
yes. So there are, first thing is that in the second wave, almost the same proportion of children below 14 or 18 years are in. So they are sort of relatively protected. Second, India is among the first few countries where pediatric vaccine trial is going on, and towards the end of fourth quarter of this year or first quarter of next year, we should be able to offer vaccines to our children. Third, that I think God is very kind to our children. So the risk of severity is very low. However, the children who have comorbidities, that means congenital malformations, neurodevelopment disorders, malignancies or diseases which are requiring steroids, they need to be taken care of very carefully. And in case they develop serious illness, they should be promptly managed. And therefore, this is in the context that our pediatric services need to be strengthened. Neelam talked very nicely that what all infrastructure is required. And I must tell you that the government has taken up this at a very serious level. And in the process, every medical college has been told that they prepare a floor with ICU and the standalone management of severe children in the pediatric ward. And this has become mandatory for all medical schools, and it has to be finished, I think, by the end of June or July. So there are these regulatory efforts have been put in, and I think as pediatrician, we should be very happy that this has come up as a opportunity to strengthen our health services for children.
Sir, and what about the neonatal?
Naren bhai, the follow-up question to this question, which you have just answered, what about pregnant women and lactating women getting vaccination in India? What is the status currently?
Lactating mothers are already are eligible for getting vaccine.
Okay.
And for pregnant women, call me after 2 weeks and I'll let you know.
Okay. Thank you.
In other words, I'm saying in next 2 weeks, the decision will be made.
Okay.
Great.
Thank you so much. Thank you so
I
much.
think now we will perhaps that bring the end of the discussion. The time is over. And before I hand it over to Mr. Tiwari, let me again say thanks to all my learned speakers. Professor Mishra, Professor N.K. Arora, Sunila Gargi, Shefali, Nandini, and Dr. Neelam, Arvind. Thank you for very valuable contribution. Tiwari ji, आज का टॉपिक इतना इम्पोर्टेंट है कि each and every topic should be included in your double helical.
मालूम है यहाँ ना खुदा हुआ है सबसे लास्ट लेन बिल्कुल वही मेरे पास आँख बंद करके
ठीक है.
And thanks a lot, sir. I really welcome to all of you, Dr. M.C. Mishra.
Again, and I want to say bye for now.
Professor Arun Agarwal for wonderfully moderating.
Yeah, the credit goes to him for wonderful moderating.
All speakers were wonderful. Shefali, you were as wonderful as ever. And Neelam, Arvind ji, Nandini ji, everyone was really forthcoming and we learnt a lot.
Thank you very, very much, sir. Thanks, yeah. Thank you very much.
Was by Dr. Sunila.
And thanks a lot for double helical. We always obliged and we request to in future, please join with us. And if you have time to write your article in our magazine. Thank you.
तिवारी जी जब सर्कमस्टेंसेस इंप्रूव कर जाएंगे तो कम से कम दिल्ली वाले एक बार फिजिकली मिलेंगे ओवर ए कप ऑफ कॉफी.
Of course, we organize the tea party, sir, for all of you.
ये मैंने indirect hint किया था.
And Dr. Narendra Arora for clarifying issues pertaining to so beautifully, so convincingly.
Yes, these are the practical queries in everybody's mind.
Yeah, in all
Thank
of
you,
us.
NK.
Thank you, sir. Namaskar to all of you. Namaskar.
Namaskar.
Bye for now.
Safe,
Thank you,
be
sir.
healthy. Take care.
Thank you, sir.
अरे नहीं